You saw the hierarchy in terms of a non-hierarchical system that we work in, but it is a hierarchy. So once you've done medical school, you do internship. Now, how you get an intern job, it's constantly changing. People are always talking about it. My understanding is it's not merit-based at the moment, I don't think. People probably talk about it changing. They've been talking about it changing for years, actually. It might happen. But after you get that intern job and you go your different pathways, there is context about programs. I think that it's often not spoken about, but we should speak about it because it's life. And that is to say that getting into specialty programs is competitive, and research is relevant to that. So there'll be a lot of people who do research because it is a necessity to meet the criteria for various programs. There's a whole bunch of point systems for different specialties. You can find them online. But I'm going to talk about what happens after that, which is to say, you're in a program, you're on the program, great. I've been working together on this program for years. But research is still really important and really fun. I don't stop just because it's not relevant to my points anymore. I've got all my points. So I actually think it's more important. And I think it really helps you as you start to transition to be closer to a consultant. I defer to consultants in that regard. And the first point is that research in advanced training is often mandatory. Most advanced training programs will have a research project component. And these are projects that are undertaken by people who are, again, working full-time. And it's, sometimes it's hard. You've got, 100-hour fortnight, 150-hour fortnight, got to get my research project done. May as well make it something that you enjoy, something that's going to contribute meaningfully, and that meets your criteria. Now, the criteria for what that project is, one, will probably change before most of you are in those types of specialty pathways. But at the moment, the threshold to clear actually is often not that high. Often it's just having done a project and submitted it to a journal, let alone whether it's been accepted or not. But rather than focusing on the criteria, I think it's important to think about what do I actually want to do with this project so that it's not just the extra thing on top of my 150-hour fortnight. The other thing is that research can actually be a part of your specialty training program. Again, this will vary by specialty and will probably vary before you are doing specialty training. But the way specialty programs work is generally you have accredited terms you need to do. So you need to do a certain number of accredited terms in a certain area or fields, and then you get your specialty program qualification. So for example, for neurology at the moment, you do 2 core years, you do 1 non-core year. Varies by program. Now, you saw in Brandon's kind of hierarchy there the position of an unaccredited position. So often you'll see people in a hospital who are doing a registrar job, who are called the registrar, who are actually not on a program. They'll be doing an unaccredited term. Unaccredited registrar, service registrar. These are terms you might hear thrown around in a hospital environment and not know what they mean. Now, they're people who are doing clinical work who don't contribute to the time that they need to do or their qualification criteria. You can actually, in some specialties, do research to contribute to your specialty qualification as an accredited term. So that's to say, instead of doing another 6 months of X clinic, you could actually take out time to do full-time research and have it go towards your specialty training qualification. And it's often the pathway less travelled, just anecdotally. Often people have a fairly clear kind of pathway through advanced training that they'll follow just because it's what the person did before that, and the person who did before that, and the person who did before that. But if you actually look at the criteria and inquire and do it prospectively, you can find these opportunities. And if you can do it and advance your qualification at the same time, all the better. The other thing is that higher degrees by research can be really important for a variety of reasons, and doing postgraduate medical training does not preclude you from doing a higher degree by research. There's now the doctorate program that's kicking off soon. There's now special pathways around that. But the other thing is that a lot of people will do both. There's no rules to say you can't do specialty training and a master's at the same time if you meet all the relevant criteria. And some people balance this really well, and a lot of people do it pretty commonly. Because you have to balance it. You're doing a lot of clinical hours. You have to be able to do it ideally in an environment that's not going to be in person for 70 hours a week because you're at work 70 hours a week. But you can often do these degrees online or with reduced in-person contact hours. And that also means you don't have to be geographically limited. So for example, say you trained at the University of Adelaide, then you've gone to work as a service registrar in orthopaedics in Victoria, but you want to do a higher degree by research, do a master's, you could potentially still do it at the University of Adelaide. I have to review the criteria and probably changes constantly around specifications, around how many contact hours are required. But you can actually do these things either remotely or with concentrated contact hours. Similarly, if you're training in South Australia but you're looking to do a higher degree in research somewhere else, you can employ similar strategies. And this is important because you can do research for the sake of research, you can do research for many reasons, but if you're doing important research that's going to meet the criteria for a higher degree by research, it makes sense to get recognised for it. And then I think the final point, I tried to keep this relatively focused because I appreciate it's after work for everyone, that advanced training is a time where you're really looking at, I'm going to be a consultant soon. Like, I know 6th year, frightening time. Like, man, I'm going to have to make decisions. MD, make decisions, terrible, terrifying. Or how many slow K do I give this patient? The potassium's 3.1. I didn't read a book about that. But you really should be supported throughout most of these processes. These aren't kind of huge life-altering decisions normally. But one thing that's been really hitting home to me as I get closer towards the end of advanced training is you're going to be making these decisions for people for MS. They're going to be on a disease-modifying treatment for potentially years. And it really hits home that I need to find the best information I can find to make these decisions. And it's not always readily available. So when you're working in clinic, a lot of people here have probably done some work on the wards, standard ward round structure, you go around, see everyone with the team, people have paper rounds. But you often don't see too much as clinics. In a clinic, you often have kind of a solo operator. They've got patients coming in to visit them. And it's when, as an advanced trainee, you really get put on the spot. It's just me. I'm really doing some thinking here. I can go get a consultant afterwards to answer some questions. But it means that when you get asked a really tricky question or, this person might have RCVS. If they're in RCVS, they should probably be in hospital. What dose do I give? I don't remember this. Check ETG. Well, it's not in ETG. Check up to date. It's not an up to date. So what do? You turn your monitor away from the patient and you Google it. I'm just kidding. But seriously, sometimes you do that. And then you look on PubMed, and sometimes that's how you find your best research questions. Because I need to make this decision. I need to make this decision for this person who I am caring for, and I cannot find an answer. I cannot give this person an evidence-based answer. Well, I'm going to go home, I'm going to work out the answer. So next time it comes up, I can make a better decision, hopefully help other people make it too. So this is how I've come up with a lot of the research questions that we work on as a group, and a lot of people in this room have worked on. So these are some examples of the ones that we've done probably in the last 12 months or so, just about questions that I personally was finding vexing and wanted to try and find some answers to. So, for example, Tom Wiseman's here. He did a great one. So, general medicine, we care about anemia. Anemia is important. You need hematinitics to make hemoglobin. You need hemoglobin to perfuse the brain. That's why I remember that. So, sometimes you do gen med, and for context, B12 hangs around for a long time. Your body's got good stores of it, shouldn't change quickly. You're on a gen med ward round, you say, this person's anemic, wonder what their B12 is. Oh, their B12 is normal, that's good. Their B12 was also normal yesterday. I guess that's good. Their B12 was normal twice yesterday. We've tested their B12 how many times in 2 days? And there's a variety of factors that contribute to this. You see that? How often does this actually happen? Well, you can actually work that out. And then you can really try and quantify that and try and make decisions and practice changes based upon that. Same thing, I'm seeing this patient in neurology clinic. I think they might have myasthenia gravis. I'm going to do an ice pack test. I know that's a thing. I remembered that test. It's interesting. I'm going to go get my ice. I'm going to apply it. Wait. How long do I wait? How long do I wait to do an ice pack test for? Put it on the eye and wait for a while. Some sources say a couple of minutes. We'll do it for 2 minutes. Okay, it didn't work. How sensitive is that? oh, this source says it's pretty sensitive, but this one says it's not sensitive at all. I wonder actually what the literature says about this. So as you are becoming closer to kind of the end, although it never really ends, your medical training, that's when some of these really important questions start to hit home for me. I think other more expert clinicians can probably talk to it better than I can, but I think that really highlights how research can influence your practice on a daily basis and hopefully inform the practice of others.